Okay, I'm going to take you guys to the Kashlak outpatient clinic. So we are seeing Joanne. She's a 56-year-old woman coming back for a follow-up appointment for her high blood pressure. A month ago, her blood pressure in the clinic was 170 over 98. And because you had listened to Dr. Cohen's last episode, you started her on a calcium channel blocker and an angiotensin receptor blocker combo pill containing olmesartan and amlodipine. Today in the clinic, her blood pressure is reading 160 over 96. And then when you recheck it, it's 150 over 94. Well, I feel like there's no more bread and butter topic than hypertension, but just so we all kind of start on the same page, how do you define hypertension?
So I personally ascribe to the ACC-AHA guidelines from 2017, and it sounds like on everyone that I've spoken to recently really is sticking with this. There are some conflicting guidelines, like the ACPA-AFP guidelines, but for the most part, folks are agreeing 130 over 80 is really great to use for somebody as your goal blood pressure threshold for sure. And if someone has any risk factor, definitely for your threshold for diagnosing hypertension as well. So this person's already on treatment. Her goal should be less than 130 over 80. In older patients, people over the age of 60, which doesn't apply to her, there are some of these less stringent thresholds, like 150 over 90 for the JNC8, for example. No one's ascribing to that anymore. In that case, somebody's running even in the 140s would be considered to be elevated. And I think that many people still have it fixed in their head that 140s is okay. 140s is really not okay. I think some guidelines using that threshold of 140 over 90, it's reasonable depending on the patient. I'm still really a fan of 130 over 80 though, because of growing evidence of how a lower blood pressure really is associated with a lower risk of adverse outcomes.
And Paul, we've been talking about this now, right? With blood sugar, with lipids, with blood pressure. Lower is better. It matters a little bit how you get there. So, but yeah. especially for patients, like if you can get them under 130 over 80, it's, I wouldn't pull away medications. And Jordy, I think it's like if you have someone in the 130s over 80, and they're already on 4 or 5 meds, it's like, do you really add another medication? That's kind of where I struggle with the 130 over 80.
Yeah, and we can talk more about that as we go into the subsequent cases too. I think that a lot of that comes down to who's the patient, having goals of care conversations. If this is someone who's going to tell you, if you prescribe one more medication for me, it's going to be one med that I don't take, then that's your decision right there. But I think it's worth a shot if the person can do it without ending up crawling out of the office.
Thank you. Okay. So mechanisms of hypertension, reading about resistant and refractory hypertension, I came across this concept of sympathetic driven versus this like sort of RAS driven. Can you speak to those a little bit?
Yeah. So hypertension is multifactorial, and we're talking about just essential hypertension, right? Or what a lot of us hypertension nerds think of as primary hypertension, just run-of-the-mill hypertension without a clear secondary cause. And there are two contributory mechanisms, and I think for most people it's likely a mix of the two, but some people there's one that's more dominant than the other. And it's either the RAS-driven mechanism, which is really your volume sensitivity. This is your renin-angiotensin system being on overdrive, meaning that you're most likely more salt sensitive. You most likely have some extra fluid or plasma volume on board, even if you're not seeing edema in somebody, even if you're not seeing signs of ascites. This isn't like the frank, I need a nephrologist to help me do a volume exam type of situation. This is just extra volume in their body, but in all the hidden places. And then the alternative is this more sympathetically driven hypertension, which are your people who have a little bit more active fight or flight process. And that's the people who maybe are a little bit more anxious and say they think that their hypertension may be causing or linked to their anxiety, but not always. People who maybe have a little more symptomatic hypertension, that's often the more sympathetically driven people. And just people who you can see that their hypertension tends to be a little bit more triggered by things besides salt. People who have more hypertension may be triggered by drinking too much caffeine. We don't see that unless people really go overboard, but our generation introduced the idea of venti coffee. So I love reading labels and realizing that Starbucks coffee has 150 milligrams of caffeine in their smaller coffees compared to a cup of like old school Folgers that our parents drank that had less than 50 milligrams per cup of the same size cup. And I've learned when you ask a patient how many cups of coffee do you drink a day, if they tell you 3, that could be 36 ounces of coffee that are each 400 milligrams of caffeine. So I never used to believe that caffeine could contribute to hypertension, but now I do, having seen some interventions that actually were quite effective at having people cut back. So I think a little bit is absolutely fine, a couple cups, but sorry, that's a side note, but those are the sympathetically driven patients. But we all see these patients, right? And so again, it's all often a mix. It's rare that people don't have a little bit of both, which is why those fixed dose combination drugs are really fantastic, because it gives you a little bit of bang for your buck on all ends. You get a little bit of a vasodilatory effect from your calcium channel blocker, from your angiotensin receptor blocker or ACE inhibitor. You get a little bit of that RAS effect from the ARB ACE inhibitor, or from a thiazide diuretic or a thiazide-like diuretic with those first-line agents. And that's why they're so effective. They target all of this.
That is great.
Somewhere in the background of the mix, my dum-dum brain, back when I thought about essential hypertension, it was this nice, straightforward mechanistic. The arteries are getting harder, and that's why the pressure is going up. Is that happening quietly in the background? Have we thrown that out the door? Is that sort of more along the sort of RAS-driven thing, or sort of what do we do with that additional sort of? Is it historical at this point to even think that way now?
No, it's completely correct. As people get older, your blood vessels stiffen. It's called vascular aging is the term for it. It's more common in developed countries than it is in places around the world who don't have as much sodium exposure. So, for instance, there's this really cool old research that was done in the Yanomami tribe in the Amazon that never had any exposure to Western food or Western diet, and they were very isolated, and researchers would go in and they had very regimented allowances of how many people were allowed to be there because they didn't want to introduce anything from the outside world, not to mention upset the tribal, the way that the function of the tribe and sort of get in the way of their usual day-to-day activities. And they would measure their urine sodium content, they would measure their blood pressures, and they would capture it across entire villages. And what they observed is that in these villages, people at age 8 had the same blood pressure as people at age 60 or 70. They did not see a rise in blood pressure with aging. And so a lot of that is thought to be due to likely the fact that our sodium diets and just our Western exposures, probably pollution, probably a lot of other stressors and things in our life that don't exist in that type of a world, contribute to vascular aging and contribute to why we develop hypertension as we get older. There's also likely upregulation of RAS involved too. So it's a bit multifactorial. But we know for sure that vascular aging is real. We know that it's accelerated in certain disease states. For example, in chronic kidney disease, people have worse vascular aging that's faster at a younger age, this vascular stiffening, and especially in their large blood vessels. And that's related to part of why we see higher risk of heart disease and progression of chronic kidney disease in many of these patients. Also, we know that as your blood vessels stiffen as you get older, it causes other damage to your small blood vessels. I led a study actually last year that was published where we found some causal suggestion that if you have high blood pressure and your blood vessels are getting stiffer faster and other factors that are causing your blood vessels to be stiffer, that actually can cause type 2 diabetes. And so that hadn't been previously really demonstrated using true causal mechanisms. I wouldn't say it's actually proven yet. We need more studies to show that. But this is a real problem. And I think that a lot of it comes from the things we put in our bodies and expose ourselves to.
Wow, I had not heard that before. I think I did come across something as I was reading about resistant hypertension that those patients are more likely to have diabetes. I'm not sure if it's the same mechanism or not, but that's scary.
There's more to learn in that space for sure, but it's been there've been sneaky signals here and there over time, and so we're starting to understand why it's happening.